In this next section of the acute coronary syndromes, we're going to look at the definition, presentation, and diagnosis so we can answer what is the most likely diagnosis in that opening sentence. You cannot determine the precise etiology of chest pain simply from a history and physical. It is impossible. You cannot tell if someone's having an infarction or ischemia simply from chest pain. You can only know after you have the enzymes or you've done catheterization in the EKG. Risk factors help you, but they don't tell you for sure. All you know is that someone has chest pain. An acute coronary syndrome means that the person's coming in with typical chest pain, crushing, squeezing, pressure, substernal, 10 minutes, 15 minutes, 30 minutes, often waking them up out of sleep. All you know is the history and the EKG. History and the EKG. Does the EKG have ST elevation or not? ST elevation or not? That's all you know, a history and an EKG. Or no ST elevation. Now, the reason why it says no ST elevation is because it doesn't matter whether it's ST depression or T-wave inversion, or in some cases, even normal. It's a matter of simply ST elevation, no ST elevation. You cannot tell if it is a myocardial infarction till 4, 6, 12 hours later to know whether it was a non-ST segment elevation MI or whether there ended up being no actual ischemic infarctive damage, and we call it unstable angina. Now, in the past, we used to use things like saying, well, Q waves and LDH, but these are worthless markers of being able to determine the etiology, because we have to bring up our management of acute coronary syndromes to literally 10 minutes. Within 10 minutes of someone coming to the emergency room with acute coronary syndrome, you have to have done history, physical, EKG, and made the determination of elevation, no elevation. Now, you have 30 minutes after coming to the door to give thrombolytics or 90 minutes to do the angioplasty. Remember, that's from coming to the door. I didn't say from the onset of chest pain, but from 30 minutes coming to the door, you should have gotten thrombolytics if that's the indication, or 90 minutes to balloon, but you have to make the determination within 10 minutes. Now you understand why all the management is based on a history and an EKG. What is the history and what's the EKG show? In this person, there's a clear ST segment depression in V3, 4, 5. If a person comes with crushing substernal chest pain and this EKG, there is no need to do any additional tests in order to know that you need to give treatment. Now, troponins, CK and B, should be done, but you don't need the results of any other tests in order to start therapy. This patient has ST segment elevation in V2 to V5. This person has an anterior wall myocardial infarction. This acute ST segment elevation, because nobody walks around with these, is a person who needs to go immediately to the catheterization laboratory if you have one. If not, they need aspirin and thrombolytics, beta blockers, ACE inhibitors, and statins. Although you can't tell 100% for sure until you have a CK and B and troponin later on, this is by far enough information to indicate the need for therapy. A 70-year-old woman is in the emergency department with crushing substernal pain for an hour. The pain radiates to her arm and has anxiety, sweating, nausea. The pain is sore and dull, and she clenches her fist in front of her chest. She's got everything for ischemic heart disease. What's most likely to be found in this patient? This question is really saying, do you know what physical finding is most likely to be found in acute coronary syndrome? The only one of these that's found in acute coronary syndrome is an S4 gallop, because an S4 gallop is a sign of ischemia. The left ventricle doesn't move, so you have atrial systole into a stiff, non-compliant, ischemic left ventricle. The first choice, a 10 millimeter drop in blood pressure on inhalation, is also known as a pulsus paradoxus. And pulsus paradoxus in choice A is a sign of tamponade. sign of tympanoid. Choice B, the jugular venous pressure on inhalation is also known as, choice B, that is a Kussmaul sign, and you see that with constrictive pericarditis. Choice C, the triphasic scratchy sound, is also known as a rub, and rub is seen in pericarditis. Choice D, the machinery murmur, continuous machinery murmur, is seen in patent ductus arteriosus, because no hole ever closes. Patent ductus arteriosus. And finally, choice F, the point of maximal impulse being displaced into the axilla, is from cardiomyopathy and left ventricular dysfunction. Let's review these physical findings again because they're an extraordinarily common source of questions on step 2. A normal person, when he inhales, what happens to venous return to the heart when you inhale? Venous return should normally increase. You should suck the blood back into your heart. Now, if you inhale and that venous return actually gets blocked up and your neck veins rise, it means that the heart just can't fill. That's a Kussmaul sign, and that is a sign of constrictive pericarditis. You have somebody who has, say, chronic tuberculosis or fibrosis of the pericardium, making it so it becomes a stiff, non-compliant box instead of flexible. Pericardial friction rub is most likely to be found in pericarditis, but remember, it's only 1/3. And we just don't see pericarditis much anymore because Dressler's syndrome, which you get after MI, well, Dressler, who was a Brooklyn cardiologist at Maimonides Medical Center once upon a time, well, Dressler was living and working before we knew that everybody should get an aspirin. So therefore, you could say everybody in the world who gets an MI is treated for Dressler's syndrome with aspirin. And that's why we just don't see it much anymore. Now, it doesn't matter if you've never been able to hear these. You have to know they're there and what they sound like. And you will be asked. There is no valve to close in a patent ductus arteriosus. And that's why the blood's moving the wrong way in both systole and diastole. The blood is moving the wrong way. And that's why it just doesn't stop. Now, when you get left ventricular hypertrophy, the tip of your left ventricle should not be extending much past the nipple, and it shouldn't be hitting the anterior chest wall. When you have dilated cardiomyopathy, not so much hypertrophic, but dilated cardiomyopathy, it actually brings the left ventricle to be touching the anterior chest wall and going out towards your axilla. And therefore, you can actually feel it pushing up against your hand. Now, it can sometimes happen when you have an acute valve rupture, but you should never see it with an acute coronary syndrome because it is impossible to have a heart attack today and to have physically dilated your heart that much, to have displaced PMI. It's impossible. It is impossible to displace your heart that much. It'd be like saying that you got pregnant and your belly extended out to the umbilicus by this afternoon. Not possible. You must know for step 2. Don't walk into that test without knowing them. And remember that you can be asked these because they play some of these murmurs for you. 70-year-old woman is back in the emergency department with crushing substernal chest pain for the last hour. Which EKG finding gives the worst prognosis? Well, this answer is ST segment elevation in the anterior leads. And you might say, well, why not in 2-3 and AVF? Because 2-3 and AVF are the inferior wall leads. And the inferior wall leads are simply not as bad. Choice E, V1 and V2, is the posterior wall. And neither inferior wall, 2-3 and AVF, nor posterior wall are going to be as dangerous as an anterior wall myocardial infarction. As an example, if you take 100 people with an anterior wall infarction, At the end of a year, untreated, 20 to 40% can be dead. Untreated. An inferior wall MI, untreated, completely untreated, only has 4 to 5% mortality. That is why the inferior wall infarction simply does not have as much bad prognosis. There's not as much congestive failure, not as much apical ballooning, not as many thrombi. All of those things happen with anterior wall infarctions, V2 to V4. PR segment prolongation is part of AV block. So simply having prolonged PR above 200 milliseconds, each small box being 50, first degree AV block simply doesn't have that much prognostic significance. AV block happens when you have infarctions of which vessels prolong the PR? The right coronary. Because the right coronary starves off that PR, starves off the AV node, because the right coronary supplies the AV node. First degree AV block has no prognostic implications, just having first degree AV block. And right bundle branch block has very little pathologic significance. Right bundle branch block does not progress. Right bundle branch block does not need a pacemaker, even a temporary one. Right bundle branch block, not bad. Left bundle branch block is dangerous, but not a right bundle branch block. It's much more benign compared to a left bundle branch block. And finally, PVCs. PVCs are worthless. People get very agitated about PVCs. People used to think, well, we got to treat people. We got to give antiarrhythmics. None of that is true. PVCs do not have the prognostic significance you think they ought to. Even if you've been trained to say, well, don't they mean that you're going to get VTAC or ventricular fibrillation? And in reality, the answer is no, actually. You think that you would, but turns out you just don't. That's why PVC should not be treated. PVC should not be treated, even with an acute infarction. Seems like our 70-year-old lady is back in the emergency room again with a crushing substernal chest pain. She's got that bad prognostic finding of ST segment elevation. Now what do you want to do about it? Wow. That's a long list, isn't it? Well, yeah, and interestingly enough, if you think about it, every one of them is partially right. Every one of these can be used and is used in acute coronary syndrome. Stop the tape and look through and see which one is the most important. The most important is aspirin. The most common wrong answer is oxygen. Oxygen is essentially worthless if you're not hypoxic. If you're not hypoxic, oxygen in acute coronary syndrome does zero for you. Nothing. Nothing. The other thing is with 1 hour of pain, CKMB will not be up because CKMB doesn't go up for 4 to 6 hours. So you should do it, but it doesn't make any difference. Troponin level is the same thing. They wouldn't be elevated at 1 hour. The only thing that can be elevated at 1 hour is a myoglobin. It's a myoglobin. But even then, even if myoglobin was in the history, even if myoglobin was a choice, it still wouldn't be right. Now, oxygen, nitrates, beta blockers, there it's all nice, but not as important as aspirin. Oxygen is essentially worthless. Sublingual nitroglycerin is not worthless. It does relieve pain, but it doesn't make you live longer. Mortality, mortality. Morphine relieves pain. Morphine relieves pain, but it's not as important as preventing you from dropping dead today. They should all be given, but they don't lower mortality. Beta blockers do lower mortality. So how come that's not correct? Because it's not dependent on time. Beta blockers lower mortality, but it doesn't matter whether we give them to you now or tomorrow. You'll get them, but they're not dependent upon time. Not like thrombolytics. Not like angioplasty. Beta blockers should be given, but time doesn't matter. Thrombolytics are very important. They're just not first. They're just not first. Angioplasty is superior to thrombolytics. But again, it's aspirin, clopidogrel, on your way into the cath lab for angioplasty or thrombolytics. Angiography is good, but aspirin is gooder. Statins are absolutely indicated in acute coronary syndrome. Absolutely. And they should be, particularly with ST elevation. They actually help, but they're not dependent on time. This is very hard to learn as a student, to know, wow, I see a whole bunch of things that all look good. How do I know which one is more important? Well, you have to answer this. Does this drug lower mortality, and is it dependent upon time? And the answer for aspirin, thrombolytics, and angioplasty is absolutely yes. The answer for statin is it lowers mortality, but not dependent on time. Don't consult people, because you don't need a consultant to tell you, give this person an aspirin. And transferring to an intensive care unit is good, but why don't we do something for this person? We don't want to have it be, hi, you're really sick. The best thing I could do for you is to get you out of here, get you another doctor. Yes, ICU is good, but aspirin, thrombolytics, and angioplasty is gooder. So start treatment first, and then you can do these other things. Learn the order in which to do things. It is not enough to know that you do them sometime. You've got to know which one should be done first and which ones don't matter whether you do them now or in 6 hours. It is indispensable. Aspirin, angioplasty, thrombolytics are critically time dependent. When you're going to give thrombolytics and you're in the emergency room, the federal standard is that they have to be in somebody's vein within 30 minutes of coming to the door. In angioplasty, you've got to have that catheter in, the balloon inflated within 90 minutes of coming to the door. Back with our 70-year-old lady in the emergency department trying to kill her off again with chest pain and ST elevation. This is a very good level of question that basically says, what do you do when they ask you, the initial therapy is done, what would you do next? All blood tests are not as important as angioplasty. Angioplasty is critically dependent upon time. The closer you can get to getting that balloon inflated to the time they come to the door, the better it is, and it must be within 90 minutes. CKMB and troponin are good to do and important to do and must be done. But this is 1 hour of pain. They will be normal at this time. Oxygen simply does not lower mortality. It's not useful. Nitroglycerin relieves pain and is an add-on. It helps. It should be done. The same as morphine. They are given, but they don't lower mortality. Thrombolytics is simply not as efficacious because angioplasty is superior in its outcome if you're asked to directly choose between them. Now, only 20% of the hospitals in the United States can do emergency angioplasty, but it still makes angioplasty superior. Now, if the question was transfer for angioplasty or thrombolytics now, and thrombolytics now is better than transfer, because transfer never allows you to get the angioplasty done right away. But when it says here you have it as a choice, use the angioplasty. Beta blockers, statins, and ACE inhibitors are all things that help, and they're all good, but angioplasty is gooder. Beta blockers, ACE and statins lower mortality, but it's not as critically dependent upon time. Time and the history. That's what drives you. Consultation is almost never right unless the consultation really means that instead of them saying angioplasty, they say cardiology consultation. So if the cardiology consultation is a code word for a procedure, that's the only time to do it. I don't need a cardiologist to tell me to give aspirin. Do it yourself. In acute coronary syndromes, the basic issue is it lower mortality? And which one should be given first? These two questions will save you completely. These two questions. Does it lower mortality? And is it dependent upon time? Let's summarize our tests for acute coronary syndrome. The EKG is abnormal immediately, instantaneously, within seconds of ischemia. That EKG can be abnormal. And the ST segments will progress to Q waves, sometimes as little as 24 to 36 hours for an inferior wall, 4, 5, 6 days for anterior wall infarctions, but it becomes abnormal with ST changes immediately. Myoglobin is the only thing that can go up in the first 4 hours. Now, myoglobin is very nonspecific. Some hospitals do it all the time. A lot of hospitals never do it. So it's entirely possible, if you're finishing your third year of medical school now, that you never saw myoglobin being done. It could have been done. And if you ever have acute coronary syndrome, you will find a negative myoglobin at 4 hours extremely reassuring. If somebody walks up to you and says, well, you know, a normal one is sensitive, but it's not specific, you'd be like, it's fine. Let it be normal, and I will relax. Myoglobin has an incredibly high negative predictive value after 4 hours. Now, CK&B and troponins don't become fully abnormal, in fact, for 12 to 18 hours. They don't begin for CK and troponins. They don't begin until 4 to 6 hours. But you can't say that the CK&B and troponin have reached 95% sensitivity until at least 12 hours after the onset of pain. The troponin lasts much longer. If CK&B lasts 1 to 2 days, troponins last 1 to 2 weeks. And that's why for detecting reinfarction, CK&B is correct. The person had chest pain, lightheadedness. They came in, they got treated for acute infarction. 4 days later, they had more pain in the hospital. Which test are you going to do? Which test are you going to do? CK&B. Because the troponin, if you have a new event, would be positive still from the first one. Questions that 5 years ago would have been considered internal medicine board questions, such as, which of the following is most appropriate to detect reinfarction? And the answer is CK&B, not troponin, are now becoming more routine on step 2. Questions that said, well, a false positive elevation because troponins are renally excreted, and patients with renal failure routinely have high troponins, would have been considered 5 and 10 years ago an internal medicine board question. But now is a step 2 question. You should just simply say, well, you know what? I am larger and better than I thought. When you have a new episode of pain a few days, the first thing is, though, the EKG. So although we said that you should check the CK&B levels, remember, all new onset pains or changes in pains should be EKG first, because after the EKG is done, then the CK&B, because the CK&B should have returned completely to normal in 2 days. If you have an infarction on Monday, your CK&B should be normal by Wednesday. If on Thursday you have new pain, that new ST segment elevation and new CK, if you have new CK 4 days later, it's from a new myocardial infarction, not the old one. The question about placement is a very big question for step 3 of USMLE. You should be anticipating that. And on step 2, it is important to know, yes, myocardial infarction, who else should go to an ICU if you're not having an ICU stay for having a heart attack? And you're in the intensive care unit because you need to be able to not just detect the arrhythmia, but to be able to do something about it. In other words, you could send them home with a Holter monitor, but you can't do emergency cardioversion if you're at home. The ICU lowers mortality. Interestingly enough, ICU monitoring with rapid cardioversion lowers mortality just by being there. What is the most common cause of death? It's an acute myocardial infarction. Well, it's ventricular arrhythmia. What is the most common cause of death? Ventricular arrhythmia, most common cause of death. And you have to have the ability to fix it right away. So it turns out that the person being at home with you there as an intern, yelling bonsai as you yell across the room and shock them, really helps them. It saves lives. It's the rapid access to cardioversion. Now, just because VTAC and VFib is the most common cause of death, that is not the same thing as saying, what is the most common reperfusion arrhythmia? When you get thrombolytics and you newly perfuse, When you reperfuse, you can actually get an arrhythmia, but it's not VTAC and VFib. Do you know what it is? Reperfusion arrhythmia? It's called an accelerated idioventricular rhythm. The idioventricular rhythm is at a rate of 30 to 40. That's the intrinsic ventricular rate. When it's accelerated, that means it's going 50, 60, 70. That's a reperfusion arrhythmia. It is wide complex. Looks like ventricular tachycardia, but it's not tachycardic. Reperfusion arrhythmias look like a slower version of VTAC. Don't treat them. Treat it if it's ventricular tachycardia. What do we mean by treatment? If they're unstable, shock them.